We basically reported our outcomes, Anderson's outcomes of a commonly used regimen where basically for multiple myeloma patients, we do VRD induction and then autologous transplantation with Melphalan 200, and then followed by Lenalidomide maintenance. So we did a single center retrospective study, and we included a homogeneous population who received this regimen. So we excluded patients basically who received any other induction regimens other than VRD. We excluded those who received other conditioning other than Melphalan 200. And we excluded those who received any other maintenance other than just lenalidomide monotherapy. Our study included about 187 patients, and the median follow-up, it's a long-term outcome study, so the median follow-up was about 5.3 years. We defined high-risk cytogenetics by del17p, translocation 414, translocation 1416, and amplification of 1q21. And those represented about 15.5% of our cohort. Most of our patients were in first remission, about 94%, and also about 61% had a kappa disease, and about 64% had IgG disease. The outcomes, the regimen was very well tolerated. The day 100 treatment-related mortality was 0. So that's very good news. For the responses prior to autologous transplantation, so after VRD induction and prior to transplantation, the overall response was about 94.1%. And this included 52.9% VGPR or more. And then after autologous transplantation and maintenance, the overall response rate improved to 99.5%. And this included 87.1% of VGPR or more. So continued deepening of response. In the overall cohort, the 5-year PFS was 43.1%. And the 5-year OS was 79%. And then what we did after that is that we risk stratified by the cytogenetics at diagnosis. So for the standard risk, the 5-year PFS was 47.1%, and the 5-year OS was 82.6%. Compare that to high-risk disease, where the 5-year PFS was 20.1%. And the 5-year OS was 59.2%. And then after that, what we did is a univariate followed by multivariate analysis, which showed that basically patients who have standard risk cytogenetics and those who achieve CR post-transplantation have significantly better PFS and OS. And age was significant for OS as well, but not PFS. The rates of second primary malignancies was about 9.6%, and this includes both heme malignancy and solid tumors. And this is basically similar to reported literature. I think the strength of our study is that it included a homogeneous treated population where the entire cohort was treated with the same therapies before and after transplantation. And also we have good representation of patients with advanced disease, with advanced age, where 27.3% were 66 years or older. And also we had good representation of patients with significant comorbidities, where 26.9% had a comorbidity index score of 3 or more. One of the limitations in our study is that we did not assess for MRD, because basically in our institution, we systematically started using that at a date later than the cutoff of the study. So in conclusion, the study basically shows excellent outcomes for newly diagnosed myeloma treated with this strategy, especially those with standard risk and those who achieve CR post-transplantation. But of course, there is room for improvement because, as we all know, the daratumumab is increasingly being used during induction based on the Cassiopeia and Griffin trials. And also for high-risk fit patients, busulfan Melphalan conditioning can be considered as well. And a study by Dr. Bashir in 2019 showed that there is improvement of PFS. And of course, lastly, there's all the newer modalities of BiTE therapies and CAR T therapies and drug conjugates.